All right. Well, hello, everybody. As promised, I have an emergency room physician the area that he works just became the epicenter for the coronavirus pandemic in July. Some of you may have met him before. It is my younger brother, Andy Dygert, and let's welcome him to Your Health Academy. So there he is. I think he's got to get unmuted. There he is. All right. Yeah.
Hello.
Hey, Andy, thank you for coming on the huge show today.
I'm so excited.
Yeah, and you know that we've had 3 days of snow out here in Colorado?
Boy, it sounds awesome. I can't wait for that to happen down here, but probably not.
Do you think if you go out and swim in your private pool or take a dip in the hot tub or maybe grill beside those that you would feel better about the whole situation?
I might survive it. I don't know.
Yeah. Well, we actually needed that snow because we were on fire up until then, but it's actually pretty clear now. But it was down to teens that first night. So there was a 65-degree drop in 14 hours.
Wow.
It was nuts. Yeah. So
pretty solid 80s here the whole way through.
It's humid though.
Oh yeah, very much so.
Yeah. Okay. All right. Well, real quick, just to get started, I wanted to talk about what was it that you saw in your hospitals that you work or in the patients down there. First of all, what happened at the beginning, so back in like March of this year, and then what did you start seeing more in the June, July timeframe?
So yeah, at the beginning, really even in February, we began having concern for coronavirus. It was kind of really no different than any other outbreak or concern from outbreak at that time that there's been in the past. The bird flu, any of the other flus, at least from what other ER doctors who are older than me and have been through this have said, where we had people worried about it. All of them tested negative. It was kind of life as usual, but everybody was talking about that. And honestly, in Florida, we started to have a few cases in March. And then in April, we had more, but it was generally a lot lower during the lockdown phase. So in April, when everybody went into lockdown, including Florida, we were still only seeing occasional cases. Now, we had some bad ones, but they were almost all travelers from another part of the world. We get a lot of people on the east coast of Florida here from New York, New Jersey area, and that's probably the most people that had coronavirus here. We may or may not have had some local cases as well, but it was very much more a travel, higher class population at that time that was coming here with the coronavirus. Older population too, because obviously a lot of vacationers, elderly people come down to Florida at that time of year.
I see. Okay. Do you think that some of the seeding that happened down there in Florida could have potentially come from New York?
Yes, it makes sense because, again, most of the cases, and I'm extrapolating from what I saw and what I heard from my fellow ER doctors and of course other doctors in the hospitals, but was that they weren't seeing people who lived down here, the younger population that works and lives down here year round so much having this. It was people from New York, New Jersey, from London. We Fort Lauderdale, which is just south of me, has a
So
large.
That's what you were actually seeing in the ER there?
Yeah, we saw exactly.
Okay.
ER and especially the sick ones, the ones that needed the ICU, that were potentially becoming intubated, even that early on, because we did have the cases that we did see in the hospital tended to be more severe.
Yeah.
And they, most of them tended to be travelers. Now, we couldn't say it wasn't all of them, and there probably was some local spread, but it certainly changed drastically as time went on.
Right. Well, you have a couple of international airports down there too, don't you?
Yeah. Oh, yeah. In fact, we have, four big international airports within 2 hours of me here.
Right.
including one in West Palm Beach, which is right around where I am, and Fort Lauderdale, which is one of the biggest um, uh, port cities in America. A lot of cruise ships and everything go through there. It is also one of the largest immigration centers in the world, and in the United States. There in Fort Lauderdale, which is just an hour south. So we
Gotcha.
get a lot of people from other countries were coming in, and I noticed a lot from Europe who had the coronavirus as well.
Okay.
For
I
several.
see. So when you have a coronavirus patient come in, like, do you know it right away, or do they look like any other pneumonia?
Yeah, they look like any other viral pneumonia, I will say, because viral pneumonias do tend to look a little bit different, but not that you can say for sure, because you can't. But no, it just was like any cold virus, because that's what this is a cold virus.
Mm.
It was a little bit different in that it tends to present more with the fever and breathing, as opposed to the sore throat, and it really doesn't seem to, maybe in some, but for most people it didn't have that type of phenomenon, the sore throat and then congestion and then coughing that we see in most viruses. It was instead this straight to coughing and fever and kind of a dry cough with not much congestion, and then
Then respiratory
breathing,
distress.
then respiratory, and then later they would have some sore throat and body aches and all the other things.
Yeah. Now, what I've heard, and you can let me know more about this, but what I've heard is that when they come in, they're not puffing like a emphysema patient. They're just very, very hypoxic and kind of feel just short of breath in general, but they're not excessively labored breathing. Is that correct?
Right. For most of them, that is true on. Obviously, in the ER, because we get a lot of patients directly from nursing facilities and things like that, there are lots of people with comorbidities, as severe asthma, COPD, congestive heart failure. These things that tend to make it the more puffing type, but most of them, no. Most of them they just start feeling bad. They may have a fever, and then they come to us and we put them on the pulse oximeter, which it goes on your finger and it shows your oxygen levels. And that would show them much, much lower than you would expect for someone who's sitting there talking to you saying, oh, I just have a little fever. And I'm worried because there's this virus going on.
Yeah. Yeah. And that's what I've been hearing pretty much from everywhere in the country.
Right.
So now, what about June, July? What did you start seeing then?
So yeah, we had like a lot of the country, I believe, we had a downtrend even during June, and they were starting to relax the strictness of everything, not totally, but a little bit.
Mm-hmm.
And then all of a sudden at the end of June, we started having an increase. And then in July, it got much, much worse. We quickly became, the active epicenter of in America of it. And it was mostly here. It was mostly in, Miami, to be honest, so I wasn't in the actual epicenter, which
you're about an hour north of Miami, right?
an hour and a half to 2,
okay.
Yeah, depending on where we're talking. But this whole area from Miami up to West Palm Beach is basically city. There's little stretches of countryside in between, but it's pretty built up that whole way. South Florida, when people talk about that, that's this. So this whole part, because of how populous it is, was really where it took off in Florida. And so the West Palm area, which I'm just north of West Palm, Jupiter's part of West Palm complex area, is what got hit pretty decently. And so, yes, all of a sudden we started seeing coronavirus much more frequently in the ER. We were seeing, everybody was coming in with this. We'd actually seen a downturn in ER patients during the spring. Like, people weren't wanting to come in for obvious reasons because of the virus.
We're going to talk more about that in a minute. Yeah.
But it had been coming back in June. Like, people had been coming back. And now all of a sudden we were also having all these viral patients. And so for a while there, it was everybody together. which made it a much tougher situation. And that's one of the reasons Florida got hit so hard, most likely.
Yeah. Well, plus you all were, I mean, another theory is that you all were starting to go inside more often because of how hot it is down there, or how hot
Absolutely.
it starts to get down there. And then kind of opposite from, being indoors up in colder weather, Florida, it's gorgeous down there in March. So it's a little bit different dynamic when it comes to being in enclosed spaces. So I know that's another theory. It's probably a multifactorial issue.
It's absolutely multifactorial. There's no question about that. I mean, I think it'll take a while to look back and say, oh, for sure, this is the epidemiology of this disease. And obviously it's going to be a little while. But yeah, considering you saw the outbreaks in June, July were Arizona, Texas, Southern California, and Southern Florida,
Mm-hmm.
I think that's a very reasonable assumption that, because yes, everybody goes inside. Nobody's outside in the 95, 100% humidity of South Florida in the middle of the day during June and July and August.
Well, for those 2 months, Andy, it's really nice in Colorado. So
hey, well, maybe we'll switch it up there a little bit.
Okay. Yeah. Well, something of note, I think, is that the Sun Belt in general, and definitely Florida, had a much lower case fatality rate than the Northeast did. I'm sure that's also multifactorial. For one thing, it had been a couple months, so doctors were starting to get a handle on how to on the therapeutic effort. So that's probably one thing, just adapting to the situation. Protecting the nursing homes is something that you guys did very, very strenuously down there, which is obviously a big key.
Right.
And then there's also a potential that the virus, as it little small mutations as it goes around, becomes less virulent as time goes on. So that's another postulated theory out there. So do you have any thoughts on that?
Yeah, just to briefly hit the last one first, I heard a lot about that, and I've read a lot about it. I have no insight on that whatsoever, and that's beyond.
I don't think anybody does.
No,
it's just one of those things people are throwing out there.
Yeah, it would make sense based on how the virus performed, but that's all I would know. But absolutely, we stopped treating this as a acute adult respiratory distress syndrome, which is what we were doing at first, where it's like quick intubation. And in that disease, because it is so aggressive and so deadly, you do have to, which can be caused by viral illnesses, you do have to intubate quickly and do these things quickly. And we stopped doing that because we were finding that was killing people for sure. This is you're
talking about mechanical ventilation, just to be clear for the
where you get the tube down your throat to breathe from you, the classic life support. That's what I'm talking about. And that's what was happening in New York and in Italy, where they had these very high death rates. And we think a lot of that is due to the compliance of the lung, which is how elastic the lung is, how well it can breathe up and down for you. In this disease is high compliance, meaning at least at first, where it will squish together and get that air where it needs to go very well, even though you're having all this infection in there. And so when you intubate somebody, that takes away the drive of the lungs to allow that proper collapse. And it also leaves some of the old air that was in each breath, because it's not perfect. It's not as perfect as us breathing to have this tube down your throat. It allows that in there, and your lungs get harder and harder and less compliant. And so we think we were forcing the lungs instead of preventing ARDS, ARDS, the bad lung disease. We were actually causing it to some extent, because we were making the lungs less compliant. Which
just by barotrauma or just by barotrauma, or
a lot of it would be barotrauma, exactly, but also just by basically you have the amount of volume in the lungs was in someone who's breathing normally and effectively, you're expelling the vast majority of it, and then you breathe back in how much you need, and then it kind of works together. When you're intubated, that doesn't work nearly as well. And so if you have that volume is staying in the lungs,
the end tidal volume,
it gets worse and worse and worse. The tidal volume, exactly. Then it becomes not just the barotrauma, but also the fact that the lungs just fill up and they don't work as well. They don't expand nearly like they are supposed to. So
Mm-hmm.
between those two things, and then that causes more damage.
So, but you still had people coming in and satting in the 60s.
Oh yeah, but they were fine. They were not fine. But
so what do you have to do for them if you can't ventilate?
So what you do is you still ventilate, but you do it without intubation. And what we do is we have things that can provide. It's called in-tidal pressure, and it's where you basically help the lung to inflate, but then you allow the body to do the rest. And so there's a BiPAP. You may have seen the big masks on people. It's like the CPAP that people wear at home for sleep apnea, and it helps to force that volume open. But we were avoiding that because there was all this concern for spreading the virus further with this thing that's causing all this ventilation. But there's also high flow nasal cannula, which is like a regular nasal cannula, just the prongs that people put in their nose to breathe in the hospital.
Yep.
Or at home. But this one is fitted better, and it has circulatory air in it to kind of allow a higher volume of air to go in at once, to allow you to take those deep breaths, and it gives you some of that PEEP, that in pressure, to help the alveoli expand, and allow you to give a lot more oxygen through it safely. And that is very little spread.
Of all the factors, I mean, obviously, you all were using remdesivir, correct?
There was one of my hospitals
not very much
throwing it in, but it was here or there, to be honest.
Yeah.
Like,
well, I don't think, it doesn't sound to me, so just for your purposes, remdesivir is an antiviral that's been emergency approved by the FDA as a treatment because it's shown at least some minimal effectiveness in early studies, and it does seem to be safe. But it sounds to me like the management of the respiratory issue from a ventilation standpoint probably is a bigger factor than that. Would you say?
It certainly.
Or what about the other therapeutics like steroids and stuff like that?
So we weren't, yeah, and that's another part of it. So yeah, I didn't personally, although in the ER, I'm not the right person to speak to, obviously, about like the long-term how the patient did.
Well, what am I talking to you for then?
I know, right? But I do start all of the therapeutics, including, steroids, and I do work with the intensivists, the ICU doctors, on, how these patients do. Also, I work in community hospitals, meaning it's not massive hospitals with tons and thousands of doctors and can manage every little thing. So we actually, in my hospitals, the ER doctors go up to the ICU. At times the intensivists are not there, and we do procedures, intubate, help with any, decompensating patient. So I do see that on the inpatient side to some degree. So therefore, all I can say is that I didn't see any difference necessarily with most of these therapeutics that are less aggressive, and it seemed the same for my intensivists, where remdesivir, hydroxychloroquine, I don't have anything against them. I don't know if there was any long-term value one way or the other, but I certainly didn't see an acute difference. Now, the one thing that I did see is steroids. Yeah. So at the very beginning of all of this, because there were various concerns and very, very poorly done studies, unfortunately, both steroids and NSAIDs, which are non-steroidal anti-inflammatory, so ibuprofen, Motrin, that type of thing, were both said, oh, don't give these are going to harm people. And it doesn't make any sense, because that's how we treat viruses. We treat them by treating the inflammation, because that's all you can treat. The antivirals notoriously don't work very well. And most of these antivirals are very targeted at specific diseases, like they were made to treat hepatitis, or they were made to treat HIV. So they're not made to treat the common cold.
Right. Well, remdesivir was an HIV drug, if I'm remembering correctly.
I believe that's true.
Yeah, I think so.
I think it became that. It actually started maybe even from a hepatitis, but I don't know. I'm not an expert at that, but at all. But the steroids always made sense. That's how we treat bad viral illness, and people weren't giving it. And I got lucky in that the intensivists where I worked, so even in February when we had our first cases, the very end of February, beginning of March, they were on board with using steroids. Which was kind of totally against the country's thing. And I can't say for sure, because we're talking about a very few amount of cases. So that does not correlate to causation.
Were you guys using DAX, or were you or systemic steroids of some kind?
They were using solumedrol, but they were
Okay.
using low dose solumedrol, which makes just as much sense as using the doses of dexamethasone.
Any Pulmicort, any inhaled steroids?
We weren't doing that, but it would have been, as far as I know, but it would have been very viable to do that as well.
Yeah.
And I know that they were advising that when patients were sent home with asthma and this at the time. We were thinking that. That doesn't necessarily seem to have played out in studies one way or the other, but we won't know that for a couple of years, probably. We still don't know that.
Yeah, but that's one of those treatments. You know me. I think steroids fix a lot of stuff, and they're about my favorite. But they've been used for so long. They're old as dirt, and you have to watch some things, but they're reasonably safe too. So I think you guys were on the ball there.
They're safe and effective for what they do. And we certainly saw that our death rate, even of those early cases, where these are the same patients, because essentially these were New Yorkers, these were people from New Jersey and London and various places that were getting hit.
Right.
And at least in our hospital system, we had a very low death rate. Now, does that correlate? I don't know. It could have just been that it was a small hospital, not getting hit hard. We had all the access. We didn't have, rooms tied up like they did in New York, which was obviously a huge factor in how many people died. Was they didn't have enough doctors. They didn't have enough space, and they had way too many patients. But so it's impossible to correlate that for sure. But it seems reasonable that had some effect. That's, I guess, what I've seen, what I would say.
I would say is of a factor out of many.
For sure.
Yeah,
for sure, in my opinion.
Yes. Well, you guys, your numbers really were pretty impressive, and you seem to have gotten over the worst of it. Knock on wood. Nobody knows 100% for sure what's going to happen, but no place that's had a big spike. No place in Europe, no place in America has had a second big spike as of yet. So. Could that be due to cross-reactivity of T cells, et cetera? Who knows? But that seems to be holding up thus far, and that would be just fantastic, wouldn't it? It would get the country back to
good.
Get things back to normal a little bit sooner.
I can't speak to New York, but even and they were way worse than we were with how bad it was there. But in Florida in July, it was very. It wasn't awful if you were just out and about. You only noticed because of the lack of people out and the masks and everything. Right. But in hospitals, it was very, scarier and more for patients and everybody, and more congested for sure. Although, like you said, we had much fewer deaths and everything like that. Intubated, because we weren't intubating and all these things as much either. So.
Yeah, and really, your hospital systems never were overwhelmed to the extent as, and definitely not as in Europe, and then also up in the Northeast. Now, talking about the lockdowns, I've got some numbers I want to read for you here. I know you know some of these.
Sure. This
is from JAMA. 46.4% less cancer diagnoses for those several months since the lockdown started. 38% reduction in cath labs treating ST elevation heart attacks, and then similar numbers for strokes and then acute appendicitis. So we're talking more than 1 out of every 3 heart attacks, strokes, and acute appies didn't even show up at the hospital, probably because of fear, intimidation of being exposed to what they thought was a worse condition with the COVID.
Absolutely.
Have you seen any of that?
It's not like these things disappeared. So no. Yeah. Oh, hugely. Yeah. So in the ER, we see a fairly consistent, you can have runs of things, but we see a fairly consistent amount of heart attacks and strokes and things really year round. Obviously it can change a little bit depending on, if you have winter, you can have a slightly increased in certain times, like holiday heart and things like that.
Yeah.
But overall, it's pretty consistent, at least with those types of things. And we saw a drastic reduction. No question. We went from having 140 patients, for instance, in one ER every single day, down all the way to less than 50 at one time, which is a massive decrease for an emergency room. So. And a lot of those patients, yes, we have frivolous things come into the ER, or just smaller things like cuts and things, but a lot of those patients,
Mosquito bites.
yeah, well, yeah, occasionally that too. Although, in some of the parts, those can be bad. But uh, the, I mean, malaria and things don't go to the ER.
No.
But the, but for the, yeah, we weren't seeing it. But what we were seeing is an increase in people showing up dead,
Mm.
unfortunately. So you'd have people come in being coded who were been found down after,
Who knows how long?
long. And we've always had that, because that's always going to happen. Some people die at home.
Mhm.
That just happens. It's life. And especially in an area that's as elderly as the population I live with here in Florida,
Yeah.
you have that. However, considering the amount of these people, when the amount of people coming in general was low,
Hmm.
I think there's definitely a correlation there. And
Hmm.
we saw a lot of people that we were not just dying, or not dead, but dying. We saw that too, come in like with diabetic ketoacidosis, which is where the diabetes, the blood sugar has gotten really high for
Uh-huh.
whatever reason, and you come in big
Yeah.
trouble. Those numbers were very high, it seemed to me at least. And it was always the same story. Oh, I haven't gotten my insulin in this long because I didn't see my doctor since
Yeah.
February. Or I haven't been taking care of myself really, and I've been at home eating and drinking a lot, because there's nothing else to do. So those went way up. And of course, those factors, the eating a lot more, the binge drinking that's been on the rise everywhere at home, all of
Yeah.
these things are factors in all of these diseases. They make these worse. So if you are less healthy, you're not out working out, you're not, doing all of these things, you're going to have more heart attacks, you're going to have more strokes, you're going to have more diabetes problems. And these things we started seeing more and more in our ER, and are still seeing, to be honest. That
Mm.
hasn't slowed. There's still lots of people who
Yeah.
haven't seen a doctor since February.
I'm afraid that's going to linger for a while. I mean, some of these effects, people not being diagnosed with cancer as often. Vaccinations were down somewhere between 80 and 90%
Yeah.
in most places. There's going to be long-lasting public health effects from this that aren't good. I mean, I've spoken to quite a few people in law enforcement recently who are saying they've seen a lot more alcoholism, a lot more suicide,
Oh yeah.
a lot more suicides. Did you see that? I put a video up a couple weeks ago about that they came out with about the impact of the lockdown on mental health and drug abuse and alcohol abuse. I don't know if you saw that, but those numbers are scary enough. And then there's also these heart attacks and strokes that are just not coming in. I mean, I don't think for a second that they're not happening. They're probably a lot of your show up to the hospital dead patients, and nobody really talks about those. Those
Yeah.
are um, not numbers that people want to talk about necessarily. It seems like.
Right. So in the ER, always we have this kind of sector of our job which is not particularly medical. It's partially, but and it's a good quarter of what we do, which is like, so you
You
have,
put that so tactfully. I'm very impressed
right.
with you.
But so psychiatry, so people who are crazy for whatever reason, meaning they're gone off their medicines, or are diagnosed, or suicidal, or whatever. And by crazy, I mean that just as a general term.
Yeah,
Not
you lost
bad.
your tactful points with that one.
I apologize. Um, okay, psychiatric diagnoses. How's that?
Thank
So
you.
yeah,
Thank you.
I'm sorry about that. So
You,
anxiety.
you wouldn't want to be canceled.
Yeah, I know. So the and then alcohol, drug abuse, things, we see that all the time too. Accidental overdose. Well,
Mm.
that's more normal. But anyway, all of these different things. And so that has seemed, at least, I don't have numbers on it, but
Yeah, I don't think they're going to have numbers for another year or so.
yeah, but that has definitely seemed to be on the rise. And I will definitely say that the amount of depression, for sure, and anxiety that I've seen is drastically elevated. And the amount that may come in with, they have a medical reason to come in, a complaint, but then it winds up at the end of their thing. They tell you, oh, actually, I'm just anxious because of the virus, or I'm depressed because my husband died of the virus,
Yeah.
or a family member
Mm-hmm.
or somebody they know, and I have PTSD from this. And we were having a lot of that right now. This is actually when we're seeing that more and more,
Yeah.
because
Mm.
it kind of went from this band, we all banded together in, April and May, and sure, it was tough, but it was kind of, everybody was trying to come together and, do this together. And I think that, unfortunately, just like anything it's become harder and harder to do that. It's become more and more negative.
Yeah.
And and
Well,
so
people aren't working.
no,
And kids aren't going to school. When they do go to school, they have to follow all the mask rules. In Colorado, actually, students are going back to school
they're
in person.
too, for the most part,
Yeah.
just with more precautions, obviously.
But that's not everywhere. And you think about the impact of unemployment on mental health. That's huge right there. And then
Sure.
I really, really worry about what we're doing to these kids with the whole remote learning endeavor. I mean, I think it was very important at first, but it's pretty clear now that kids are not who's at high risk from this virus. And I think this is personal opinion. I would say that the negative impact on education is not worth it for the risk to the kids specifically. Now, I know that the concern mostly is for the teachers or for people who are at high risk having kids going to school, but I think some of that is overblown as well. It's a tough situation. The teachers are doing a fantastic job, almost impossible job. Have you talked to Joe about it at all? Our older brother Joe is a teacher, so it's
not specifically about that. Although
yeah,
obviously I know he's going through his own trials, trying to get prepared, like all the teachers are.
yeah.
I have two of
He's
my
doing
own.
a great job,
Yes, two of my
and of
own.
course he never complains about anything, so he'll just
Well,
be he's very positive about it.
yes, being a priest will do that to you too. So both of that. So I have two children of my own, and they are back in school now.
You have 3 now.
I know, but two that are in school.
Okay.
Thanks, I appreciate it. But,
Just trying to keep you out of trouble. Yeah.
and seeing what the schools have to go through, because some of the schools are distance learning only, some of them are doing a combination, some are just in class, and they've got all these different rules, and it changes by every school district, it seems, as well as every state, and et cetera. But it's definitely extraordinarily challenging.
The hilarious thing is that the AAP, the American Academy of Pediatrics, the recommended screen time per day. Yeah, those that's not happening during remote learning. Okay, yes. I want to switch real quick. The other day, you posted a video by Z-Dog. Z-Dog. I thought that is a fantastic video. If you haven't seen it yet, it is basically, he was saying, you need to think for yourself. You can't get yourself too intertwined with a political party of any kind, because then they're thinking for you. I think that is a beautiful discussion. Now, the problem with that is when you say stuff that's just kind of your perception of what truth is,
sure.
All of a sudden you get hate from both sides. You get hate from both parties. I loved what he called it. He said, I'm alt middle. I love that. I am a proud alt middler myself.
Yeah.
So, but it was difficult. What was that?
I said, I am as well. I'm not saying you can't be of a political party, but you just shouldn't be extreme, I guess.
Yeah. Yeah. Extreme is where the crazy happens. That was not tactful. All right. So, but I thought that was a great video. And I think it highlights an important point because, like the fighting between the political parties, like normally is annoying. But then all of a sudden, you gets to February and it's kind of like, guys, we got real problems here. We might want to quit trying to do all the gotchas and so forth. And that happened for maybe a handful of days, but then we kind of slipped right back into it. I thought that led to a lot of bias. So people kind of using studies or statistics to emphasize their point. And then there was misinformation that was spread. And I would assume that has led to significantly worse outcomes than it was if the health and political leadership in the country had been able to say, look, we're not fighting right now. This is the stuff you need to know, and come out and tell the truth. I think people would have really responded well to that, and that we probably would have done a lot better with this whole ordeal. Because you couldn't even talk for a while about, hey, you know, we might want to start reopening again because there's other things, and we just talked about those. There's other problems that are going to arise because of that. If you said that for like a month and a half there, you were castigated immediately as a grandma killer or what have you. And if you criticized the president, God forbid, for saying, you know, he's not a medical person and he doesn't convey information very well, then you'd get it from the other side. So it's a choice you have to make. Are you going to tell the truth and take the heat, or you know, just kind of be quiet and sit on the sideline? And I think it's always better to go with the truth.
For sure.
Yeah.
For sure. Well, I mean,
Yeah.
that just in something as simple as, you know, one of these medications that we briefly mentioned earlier, like the hydroxychloroquine,
Especially
thing,
hydroxychloroquine.
just absurd that it became a political statement when, but it's a drug that is very good for certain things and doesn't do much for other things, but it could potentially have some effect. And
Yeah,
that's
there were actual mechanisms of action.
Yeah. So
Yeah, that.
So,
Go ahead, I'm
like,
sorry.
I don't think any doctor or any reasonable person is against the use of hydroxychloroquine if it works. The
Right.
concern is hydroxychloroquine has very poor side effects in a certain population. So people with heart problems, basically.
Mhm.
And so it's not a benign drug, just like a lot of drugs aren't benign.
Yeah.
So therefore, that was the concern in the medical community, was just, well, we can't make this just available without testing it at all, because it had really bad things.
Oh no.
And,
Yeah.
and so, and then it became politicized of like, oh, you either have to agree with it or not agree with it. There's nothing to agree with. Does it
Yeah.
work or not, and is it safe or not? Just like the vaccine, does it work or not, and is it safe or not? But it just all becomes political.
Yeah.
But-
Certainly. I had people ask me frequently, so what do you think about hydroxychloroquine? You know, and I was kind of like,
Exactly.
I hope it works. But you know, I wasn't gonna sit there and be like, oh yeah, it's a miracle. It's gonna save everybody, because that wasn't true, and obviously it's proven not to be true. To be a game changer type of drug. Unfortunately, it would be fantastic if it was. Now,
so just like we were talking, it's an anti-inflammatory, is essentially what it does in the end. And so it has a mild effect, it appears, in some people. That's all we know right now. We don't know anything else.
well, I think it also has some effect on the angiotensin receptor. That's where the virus gets into the cell.
Right.
So
But
there was
I'm breaking it down to the non-scientific nitty-gritty.
my viewing audience, Andy, although small, is very savvy.
Very scientifically with it.
Well, that's why they were
know.
looking at ARBs there for a while. You know, that's a blood pressure. That's a blood pressure medicine that blocks the angiotensin receptor. So they were thinking the same thing at the time, and that didn't work either.
And the funny thing about that is, originally they thought that same effect is what would harm people, which is why they didn't want NSAIDs like ibuprofen to be used, because it has that same effect. But then they found that actually they seem to be protective. So then they took it to the other extreme of, okay, well, maybe then we need to block these receptors. And it just shows how ridiculous this whole thing can get with nobody knows right now.
No, yeah. Everybody was floundering.
That this has been with us forever, but we're talking about in America, we've only been studying this since January at the earliest, really. Mm-hmm. And that's no time in science at all, and certainly not in medical science. That's like nothing.
Yeah, no, that's, I mean, usually it takes several years to get a handle on what you're doing. And they really have been motoring in some of these developments, which I want to talk about real quick. So to talk about the vaccines, two of the main three that are being worked on currently are mRNA vaccines, which is a relatively new technology. I think it's kind of fascinating. And then the third one is they're using a viral vector from chimpanzees to get, it's all about the spike protein, to get the spike protein into the patient, and then the antibodies form to the spike protein. You can kind of tell, obviously this is speculative as well, but you can kind of tell that they are at least modestly encouraged by these trials, in that Robert Redfield from the CDC, he sent letters to every governor of every state and told them to be ready for distribution later this fall, just in case that would be available. I don't think he probably would have done that if they weren't seeing anything, but that's speculative.
Correct. Who knows? But
No, exactly.
It's encouraging as long as it doesn't become just a political statement, but we have no idea.
I don't think it will, Andy. I think the temperature.
I sure hope not. So
yeah. Well, it did yesterday. Did you see that? You don't even want to hear about it.
Which one?
Just Google. What's the chick's name on The View? The Behar. Google Joy Behar and Ivanka Trump, and you'll just have several minutes of entertainment for yourself right there. But I'm actually more encouraged about another therapeutic that they've been using in Israel and some in Europe, and then which is the monoclonal antibodies. I think that I'm actually more encouraged by that than I am by the vaccine. So just real quick, monoclonal antibodies are synthetic antibodies which we can make on our own, and it's sort of along the same lines as the convalescent plasma therapy, in that you take the plasma from a patient who's recovering from the virus and that they have antibodies circulating through their system. If you infuse the plasma from one of those recovering patients into a sick patient, those antibodies can help those patients. And the difference between the monoclonal antibodies is that you can concentrate that and make it a much higher dose, and it's more able to be regulated as opposed to just the random levels of antibodies that different people are going to have. So I've been encouraged by what I've been hearing on that as well. So some things to look forward to there. Yeah. What do you think? What other lessons? What lessons do you think we could learn from this pandemic so that we do better for the next one?
How long is your show? No, just kidding.
Yeah.
Somewhat. I mean, obviously,
we did pretty bad.
Well, we did. I would say, of course, we did pretty bad is kind of how I would put it. Yes, we did worse on some things than we could have done, but knowing what we knew at the beginning and considering that, so think how many times that these things haven't panned out. You know, Ebola, at least in this nation, obviously it was very bad in other nations, but the avian flu, H1N1, it's, you know, all of these things that were concern for pandemic, but they were epidemic maybe at some point, and there was, you know, this much hysteria or whatever, and then it didn't pan out. Yeah. So I feel that I kind of have to step back and take it all with a grain of salt, because nobody knew that this was going to happen, at least to the degree that it did.
Well, I'm not so much talking about that as I am about the politicization and that type of thing, because
ridiculous but expected. Unfortunately.
Well, and I think the CDC probably learned some things when it came to developing testing that won't be repeated in the future. I mean, the CDC had a rough start to this whole thing, but they really have kind of righted the ship when it comes to what they've done. I thought they've done a pretty darn good job. You know, I think providing people with information about what was coming, because no one knew for sure how bad it was going to be. But, you know, I think you kind of have to know how bad it's going to be. Or if you're the World Health Organization, you know, that's kind of your job, is to prevent the world from having an outbreak such as that. You know, it's an imperfect endeavor, and anyway, I think there'll be some lessons to be learned in the near future about public messaging. Maybe not do shutdowns next time, at least not to this extent, because they don't appear to be super effective based on any available evidence that I've seen, and they definitely cause some problems. And you know, once again, just avoiding the politicization of science, because it just corrupts it, and then all the doctors and nurses and all healthcare workers are kind of stuck. You know, just kind of like, can you guys shut up so we can do our job here? You know.
Well, I'll tell you from someone who works in a hospital, and I'm an employee of a group that works for hospitals, and a lot of what we were allowed to do, the medicines we were allowed to give, which is you're given that by administrators, people who are not medical, is based on political opinion, unfortunately.
Ugh.
and things, of course, that the World Health Organization or the CDC advises. And in this case, in the early stage of this, they completely messed it up. So, and they did things without any evidence at all, which should never ever be done by a scientific organization. That just doesn't even make sense.
Yeah.
So that would be a huge thing that needs to change, and hopefully they did learn their lesson from that, at least to some degree. But yeah, also the fact that we shouldn't jump on going away from what we know. So this virus is novel for a reason. It's different than the flu. It's different than Ebola. It's different than these other things that we've had in the past, and it's even different than other coronaviruses. But it's actually mostly similar. It just is more virulent, meaning more dangerous, more.
Yeah, it's hyper contagious.
Yes.
Yeah.
So in your body and to other people. And so although coronaviruses are extremely virulent in spreading to other people just in general, not just this one, but I guess the thought was we've known how to treat a coronavirus for a very long time. It's just very supportive treatment, anti-inflammation, and we got away from all of that. Instead of supporting patients, we went straight to, oh, we have to do the most severe treatment we have to do, and we basically lost our mind, and from the World Health Organization on down, and said, oh, there must be some novel way to treat this, which, first of all, if that exists, is probably going to take years to develop, or at least figure out, and then do. Whereas just doing basic treatment has worked extremely well in this disease. Now, some people still die, absolutely. Even some young people die. But what we forget is young people die of viruses all the time.
People don't seem to know that. Like it's like people are shocked that people die of pneumonia and of influenza and stuff like that. It's like, if you work in healthcare for a while, you see it all the time.
Absolutely. And people have things that they don't know about. And that when you hear about a 30-something-year-old who, has no medical conditions, who dies of coronavirus, but if you were to do an autopsy and figure out, they very well, first of all, there are no medical conditions is usually because most 30-somethings in the United States do not have a doctor, and do not go to see a doctor if they have one.
Yeah, so, especially guys.
Yeah, for sure. So they have no idea if they have a medical condition or not. They may have high blood pressure, beginning of diabetes or pre-diabetes. They may have a heart condition that they never knew about since birth. We have no idea if there's another factor involved. Now, coronavirus is very deadly, and I'm not downplaying that, but I just mean that in general, young people have done very well with this. I've seen it. You've seen it here. And almost all of the deaths I've seen from this disease, in fact, personally, basically all of the deaths I've seen from this disease have been elderly, sick people.
Well, the average age of death from COVID, I believe, is 80.6, if I'm not mistaken, from the CDC. I know it's over 80.
It's very high.
Yeah,
high
it's very high
for a virus, high for a disease.
Yeah. And that's kind of been the one statistic that's held true, even from what we first knew about it back in February, because you and I used to talk about it all the time, right when everything was starting to go crazy. We had a lot of phone calls where we'd be like, how come we aren't protecting the old people, very stringently, and then letting the lower risk people keep the economy going, and also helping protect the older people? That seemed to be the right thing to do at the time. I still think that's the right thing to do. And until there's, a very effective therapeutic, like hopefully maybe these monoclonal antibody treatments will be, a silver bullet. That would be awesome. But really, I mean, you think about the AIDS epidemic, it wasn't a vaccine that's helped the AIDS epidemic. It was therapeutics. So everybody talks about the vaccine, but if we had a very, very effective therapeutic, that would be just as good, if not better.
Absolutely. Oh, for sure. And, and obviously, eventually, if you have a therapeutic that protects people, you get more immunity, unlike with AIDS, where you don't really get that. So fortunately, we'll see that, it seems, with this virus, at least to some extent. We don't know what that extent is, whether it'll be like the flu, where it's like you need the seasonal re-up, or whether it's something like, one of these other viruses, chicken pox, where if you have it once, you're not going to get it again. Well, at least in that, in the way you get it, in the same way. So, yeah, but yeah, the one thing I will say, being in Florida and seeing it personally, is so we have an extremely old population in Florida, like if not the oldest, very
It's
close.
the oldest in the country.
Yeah, I was pretty sure about that, but
Yeah.
And we have a very large, assisted living, retirement home, et cetera, and nursing home population. So they very early on shut down, visitation, et cetera, in nursing homes. And we did see, like you mentioned earlier, that improvement. And what I will say is the fact that we're so incredibly elderly, our population here, and we saw so few deaths, lends at least some credence to that strategy. And I'll tell you, we had a couple of nursing homes that it got into in hospitals that I was near, and most of the deaths that I know about are from those facilities in those hospitals. Like the two facilities near one of the hospitals that I work at, like for instance, when it gets in, and they did a very good job of segregating them. So they worked as quickly as they could. It wasn't that. I'm not blaming those nursing homes, because things will happen. You can't magically stop a virus.
Well, I mean, it's just a concentrated, enclosed area of mostly old people, and
old, sick.
100% of them have pre-existing conditions. So
absolutely. So and those people, and even then, most of them survive. So comparatively, a much higher percentage die. But
right.
So we're not trying to. The point behind this whole talk is we're not trying to pass off the fact that young people can die, and you need to take this extremely seriously. There's no question about that. But the problem is that it's novel, it's sweeping through the world, and that the sheer number of people that it's infecting that have never had it before is the issue. The issue is not the amount of young people dying, because that's actually exceedingly low for the percentage that are catching it. That's the point. And the question is, well, when are those same young people harmed more by what we're doing? And not just the young people, but everybody in society harmed more by what we're doing to prevent it, which is extremely difficult to determine, obviously. But that was
almost impossible.
When we say maybe avoid the shutdown, that's what we mean, not don't help grandma, because we want to help grandma, like extremely. That's where, like you said, that's where our effort should be concentrated, even though some young people will die. But as we are seeing, some young people are going to die anyway. It's unfortunate. We will stop it if we possibly can. I would say all healthcare workers and everybody, I would say, is in agreement with that, or the Cures Act should be. But the answer may not be just try to go away and hide, because you cannot hide from this effectively, because there are other considerations that are just as dangerous, if not more dangerous.
No, I think that's well put. Well, that is pretty much all I have on my list. I thank you so much for coming on to the big show, Andy.
Oh, thanks for having me.
My first physician guest. So
my fame is endless now.
This might actually kickstart your career. You never know.
There you go.
Your new career.
No, I blinded everybody, so they won't be able to remember what I look like anyway. So
I was wondering what these little green blotches in front of my fields of vision were, but I think you're right. All right, man. Well, say hey to your family. Thank you so much for coming on and for all the outstanding information. And we'll talk to you all again soon.